So coming to the next phase, that is the tendon disrepair. This is the phase where there is greater amount of matrix breakdown, that is there is increased number of cells present in the matrix, which results in increase in protein production, that is the proteoglycan and the collagen. So this increase in the proteoglycans results in separation and disorganization of the collagen. So there may be an increase in vascularity and neuronal growth. So this stage clinically is seen in the chronically overloaded tendons. It is seen in the overloaded tendons and appears across a spectrum of ages and different loading environments. And next is the degenerative tendinopathy. So in this stage, there are areas of cell death due to apoptosis, trauma, or tenocyte exhaustion, that is decrease in the tenocyte cells. The matrix large areas are disordered and filled with vessels. There will be matrix breakdown products, there will be more of matrix breakdown products and a very little collagen left. So there is a little capacity of reversibility of the pathological changes at this stage, and this is usually seen in the older person. This is primarily seen in the older person, and there is a little capacity of reversibility of the pathological changes that has been taken place. So this is about the brief pathology, which you can divide into these three stages, that is the reactive tendinopathy, the tendon disrepair, and the degenerative tendinopathy. Next, if you see what is the clinical picture. The clinical picture, the pain, as I said earlier, will be localized to the inferior pole of the patella, and the load related pain that increases with the demand on knee extension, notably in activities that store and release energy in the patellar tendon. The patient complains of pain with prolonged sitting, squatting, and stair climbing, but these complaints are the features. Also, maybe they may be masking with other conditions like the patellofemoral pain or any other pathology around the knee. So pain is rarely experienced in a resting state. Pain occurs instantly with loading and usually ceases or reduces almost immediately when the load is removed. The pain may improve with repeated loading. An important feature of tendinopathy is that they are dose dependent. Dose dependent. Pain increases as the magnitude or rate of application of the load on the tendon increases. So I repeat, this is an important line. They are dose dependent and the pain increases as the magnitude or rate of application of the load on the tendon increases. The practical application of this is an examination. Pain should increase when progressing from a shallow to a deeper squat exercise or from a smaller to a greater hopping or hop height. Then there may be some aggravating activities such as walking down the stairs or performing a decline squat. So what are the diagnostic procedures? So on examination, the individuals will give a history of activity like jumping or hopping or those dependent knee pain. So examination of the complete lower extremity, is very much necessary to identify relevant deficits at the hip, knee and the ankle foot regions. Atrophy, reduced strength, malaligned foot posture, quadriceps and hamstring inflexibility, reduced ankle dorsiflexion are some of the factors which are seen associated with patellar tendinopathy and should be assessed properly. So this is, we are talking about the diagnostic procedure examination. As an outcome measures pain provocation, we can use the visual analog scale, or we can also check for any kind of other scale which you can score the pain. Then also while examination we have to see there is any kind of swelling around the knee, tendon swelling. Now coming to the medical management. First is the use of NSAID, non-steroidal anti-inflammatory drugs, for the pain and the swelling to get reduced. Corticosteroid injections, which are often used to decrease pain. But these injections also decrease the cell proliferation and protein production. Therefore, it could be used in the reactive tendinopathies. So, repeated peritendinous corticosteroid injection has been shown to reduce tendon diameter at 7 and 21 days after injection in tendons, which a study was done. And then lastly, if the conservative treatment fails, we have to go for the surgical treatment. Surgery for chronic painful tendons has produced varied outcomes, with 50 to 80% of athletes able to return to sport at their previous level. Surgery is considered a reasonable option in those who have failed in all conservative interventions. Now coming to the physiotherapy management, the physiotherapist should advise the persons having this condition, selective rest should be provided to allow appropriate tendon healing following a period of acute overloading or unaccustomed exercise. The focus should be early return of the athlete to the activities. For pain relief, we can use isometric exercises, which is found to be superior to the aerobic and resistance exercises reducing pain. Then a variety of loading programs are suggested for the treatment of the patellar tendinopathy, mainly on eccentric loading and eccentric concentric loading. If you go to the differential diagnosis, We have to rule out conditions like infrapatellar bursitis, fat pad syndrome or the Hoffa syndrome, patellofemoral pain, plica injuries, Osgood-Schlatter syndrome. So these are some of the other conditions which may be associated with knee pain. So we have to clearly examine the condition tendinopathy, and as I said, this particular condition is dose dependent. As we increase the load, the pain increases. Immediately when the load is waved off, the pain decreases. So which is a classical sign of this condition called jumper's knee. So if we want to see a picture of the patellar tendonitis, see, this is the patellar tendonitis. Common causes pain in the inferior patella just below the kneecap and affects about 20% of jumping athletes. And if we again want to see a picture of the anatomy, just a second. So here you can see the cross section of a tendon. The collagen fibers make up the pale pink background. The fine lines separate the fiber bundles. The black dots are the tenocyte muscles. So the quadriceps tendon. So if we summarize today's topic in a brief note, then it is jumper's knee, called as patellar tendinopathy, and the patellar tendon, that is the quadriceps muscles that forms the quadriceps tendon, crosses over the patella, the patella acts as a pulley in generating force. It is a sesamoid bone. After crossing the patella, it becomes the patellar tendon and it finally inserts into the tibial tubercle. And the pathology, there are three stages. We can divide: reactive tendinopathy, tendon disrepair, and degenerative tendinopathy. Then if you go to the clinical picture, the pain at the anterior knee pain is the most common picture. There may be also swelling, a little bit of swelling of the tendon. Then you have to examine the knee joint, the hip and the ankle, because there may be some associated mechanical factors resulting for the condition. Medical management, first is the rest and NSAIDs. Then if it is a very acute condition, we can give interval of rest and then slow loading of exercises just to ensure that the muscle surrounding the joint does not go for atrophy or does not become weak, because our focus should be the person or the athlete should return to the activities as fast as possible. And yes, at last, if it is nothing is giving result, then we can go for surgical procedure. And yes, that's all today for this topic, jumper's knee. If you have any kind of doubts or if you have any kind of confusions, please after seeing this or studying this video, feel free to ask me the doubts in our WhatsApp group or in our Google Classroom. And this is just a try, so that we do not disconnect from our activities or studies, because we are into academics and you people have to study and the knowledge sharing should go on. And so this is a try from home that I am trying to give you some kind of lectures through this YouTube or this video. You have to study the book, go through the chapter, go through my lecture. Any doubts, feel free to discuss in the Google Classroom or the WhatsApp group. Okay, students, thank you. Stay safe, stay indoors.